we're treating, we cannot deploy these excellent agents that are now available. However, there is a very big challenge. The challenge is that TTP, when it walks through the door, does not declare itself, and the differential diagnosis of a thrombotic microangiopathy is very broad. In addition to immune and congenital TTP, which this webinar will focus on, there is also the primary complement-mediated thrombotic microangiopathies, also called atypical hemolytic uremic syndrome, and a host of other secondary thrombotic microangiopathies that occur in the presence of an inciting condition, be it pregnancy, infections, hypertension, autoimmunity, transplantation, cancer, or medications. Another challenge is that the clinical manifestations of TTP are very heterogeneous, ranging from neurologic symptoms, which are quite common in TTP, all the way to symptoms such as gastrointestinal issues, chest pain, nausea, vomiting, abdominal pain that are quite common, which all goes to say that it is difficult to recognize a single pattern in presentation. And finally, the presentation is rather non-specific, which makes diagnosis challenging, and common symptoms such as abdominal pain, nausea, weakness, and sometimes quite mild neurologic abnormalities are very common, but do not scream the diagnosis in all cases. We used to talk about the classic pentad of microangiopathic hemolysis, thrombocytopenia, fever, kidney problems, and neurologic impairment. But really, this is quite rare in TTP and occurs in less than 5% of individuals in the current day. And severe deficiency of ADAMTS13, when we're able to test this, is diagnostic. But unfortunately, that's not something that's available point of care in most places. So we have tools to deal with this challenge. The gold standard is testing for the activity of the enzyme ADAMTS13. And the challenge here is that the usual assays are technically challenging and time-consuming, and they're not universally available. So if this is something that you have to send out to a reference lab and takes 3, 4, 7 days to come back, this can delay diagnosis, which is a problem. To overcome this issue, clinical decision tools such as a French score and the plasmic score have been developed. They have very high sensitivity. They're in general quite good to rule out TTP, but they're certainly not foolproof and not always validated in specific populations such as children or the elderly or pregnancy-associated thrombotic microangiopathy, making them excellent tools, but perhaps not the silver bullet that we need. So just to highlight that timely diagnosis of TTP is critical for many reasons, the first and foremost being to reduce mortality from acute TTP, but also morbidity from events such as stroke that can occur during acute TTP. For people that do not eventually have TTP, to avoid unnecessary exposure to procedures and plasma, to avoid appropriate treatment of atypical hemolytic uremic syndrome because it is frequently treated as TTP until proven otherwise. And then for immune TTP in particular, to facilitate the early use of treatments such as rituximab and caprosuzumab, etc. And in congenital TTP, ideally to minimize immunosuppression and to facilitate earlier use of novel therapies such as recombinant ADAMTS13. And with that, I will hand over to my colleagues to help us understand this.
Thank you, Shruti, for nicely framing this webinar. Then we move to our next